Thank you all for coming today. It's quite daunting, actually, talking to people you know. It's much easier standing up in front of complete strangers. So I hope this is somewhat entertaining and interesting for you. So I will start. I thought I would start a little bit by telling you how I got here. I come from Gosport. It's a little town on the south coast that lots of you will be aware of from here. And I went to the local comprehensive and had a very straightforward childhood. Mum was a teacher, Dad was a chemical engineer, and things were very straightforward. I was very lucky to get a place at King's College London. I'd been told by numerous people not to worry too much if I didn't get into medicine, but King's seemed to take a risk on me. And that was a very fortunate start. Now, I've never planned anything, so that what I found in life, and for anybody who's starting out now, that you should just take your opportunities when they come. And this started early for me with this chap called Peter Nunn, who was a biochemist at King's. I saw on a notice board a competition by the British Nutrition Foundation to write an essay associated with medicine and nutrition. And I decided I would enter this and I would do the impact of nutrition on the immune system. And I wrote this essay. It was probably pretty bad, but I found him and I didn't know him. But I said to him, would you mind looking at it for me? And he helped me put together this essay, which went ahead to win. And that's how I ended up doing nutrition. So I ended up working with in Tom's lab, very naive to the entire research world, but actually that's where I started to understand that research is something that would drive you forward and take you on. So thank you, Tom. It really did start at that point. So after King's, I did my house jobs there. I then wasn't sure. I had a very illustrious, is that the right word? Clinical time, partied quite hard, didn't win any prizes, and came out with passed exams first time, thankfully. Came out, did house jobs at King's, and then thought, what do I want to do? There's very little structure to training in those days, and I thought the anaesthetists were quite nice people, and they seemed to want to encourage me to join them, so I applied to anaesthetics. And I did a year at King's, and then a year at Eastbourne, where I met my husband Paul, who's here tonight, and then went back for a year at King's. And while I was doing the year at King's, Paul decided he wanted to do a degree in photography. So he applied to Napier University in Edinburgh, which is an excellent photography course, and got a place. And I was just about to start a registrar job doing chronic pain research as well. And I thought, oh, they won't want anybody from England in Scotland, but I'll apply. And I got a job in Edinburgh. So I ended up in Edinburgh in 1991. It was a long time ago now. The hospital was situated bang in the centre of town, and these very significant red dots are the hostelries that we frequented for long periods of time. So, you know, you'd finish at work and there were a few pubs to get to on the way home. And Scotland was very much like that. They've now moved the hospital out to the peripheries, and it's far less fun, I suspect. Again, something popped up as an opportunity, and this was my very first paper. It was surgical face masks are effective in reducing bacterial contamination caused by dispersal from the upper airway. And rather bizarrely, in the last 3 years, I've had that paper quoted to me. And I've sort of gone, oh, I wrote that. And so COVID has made it incredibly relevant again. And I've got some ideas of what I might do with that going forward, just to finish off the story. But that then got me involved with the intensive care team, who were quite proactive in the research up there. And this is where I was able to rekindle my interest. And I met this chap, Alistair Lee, who's one of the brand new liver unit consultants, ITU and liver unit. And he said to me, we've got a new research post coming up. Would you be interested in being part of it? So I applied for the job and I got it. And Alistair, in his typical way, quite a chaotic but incredibly energetic man, said to me, after I'd said, yes, I'll take the job, said to me, there is one thing. He said, it is a 1 in 1. He said, but that's illegal, so we'll pay you for a 1 in 3. Is that okay? So I did 18 months on call. Fortunately, there was plenty of warning prior to patients coming in, so I could have a drink or two and not be called in whilst somebody was unwell. If I had a patient there, I'd clearly not drink, but if there was a party going on or I had no patients, I'd have at least 10 hours notice before the patient arrived. So life wasn't completely put on hold for the job, and it was a fantastic job, and it allowed me to do my thesis. I used to sit in the clock tower. There was a room behind that clock, and I used to sit behind there because nobody could find me and do some work. But then, of course, a very important thing happened whilst I was up in Edinburgh. Oops, I've gone back forward too. Yeah. And here he is. This is Rhys. He's now sitting up the back. He's Detective Constable Clements of the Met. And that's what he looked like in 1997. So he came along in 1997, and so he's Scottish and still supports Scotland in the rugby. Just briefly, my thesis, and it's a theme that before I put this lecture together, actually, I felt that I'd gone from sort of one area to another, but there is a theme that goes through my research, and that's I've always looked at the acute changes to physiology in the unwell patient in various forms. And this started with the thesis, which was a measurement of cerebral blood flow and metabolism in acute and chronic liver disease. I used fairly old technology. This is a Harvard parallel withdrawal pump. If you put the syringes on there, they'll withdraw at absolutely the same time, and you can compare concentrations of gas in arterial and venous circulations, and then make calculations which tell you what the blood flow across that area is. And so this is what I was doing, and I was doing it in the patients who'd had liver transplants after chronic liver disease, and I also did it for patients who had acute liver disease. And effectively, what I showed in the acute liver failure patients is that a lot of the flow became dysregulated. Though the autoregulation that's normally in the brain wasn't working so well. Flows went up as cardiac output went up until you actually got cerebral edema, and then blood flow started to crash. And patients in those days, I think it's changed a bit with treatments, but a paracetamol overdose coming in with a liver failure would develop cerebral edema, and it was the cerebral edema that killed them in those days. I understand that management is different, perhaps a little better now. So that was my first foray into the acute physiology of patients. Now, Edinburgh, when I got to the point of needing a consultant job, I'd had a child, and there was an attitude that I might have to go off to a DGH to work. It was a little bit, let's say equality hadn't developed fully in Edinburgh by this point. It's very different now. Lots of women doing very interesting jobs, but at that time, I was either going to wait for a job to come up that I wanted, and there would be no guarantee that I would get it, or I'd go out to one of the DGHs. So this man, George Hall, he had supervised my thesis because it had to be a University of London one, so he'd been involved, and he said, come down to George's. So that's how I ended up in George's in 1999. Quite early on, the second very good thing happened, and he's sitting up the back. He's the taller of the two, and he's currently at University of Liverpool doing international relations and security. So I can confidently tell you that neither of them followed in my footsteps. But my time at George's was productive, and I started doing work more. There are not a lot of livers in George's, not the advanced liver stuff. So I transferred to looking at acute kidney injury. and problems around that. And I'll introduce you to some of that stuff in a minute. I also looked at glucose in the airways and how the airways are disrupted and become inflamed and glucose appears in the airway. But there was one thing I'd like to put out. I have got 2 physics papers. Never thought I'd have a physics paper. I've got 2 physics papers, which I think my dad would have been very chuffed to have known that I actually appear in a physics journal. I wouldn't say I know much about the physics in these papers, but I was the senior supervisor, and one of my PhDs was all about sound measurement. The chap we've worked with up in London is actually now at University of Sussex, so I'm still seeing him and collaborating on things with him now. So, anyway, I've got a couple of my students, my old students who are now seasoned consultants in the audience. We've got Becky Cusack and Chris Cohen have managed to come down. John and Dagan were on call, and I believe Katie is as well. So it's wonderful to see you here. So thank you for coming. And then I moved to Brighton. I don't have a baby picture of her, but I do have Izzy, who came to us. She was 16 when she came to us, and that's our daughter now, Izzy, who's joined us. And she's at University of Glasgow doing politics. So I didn't have a baby picture to put up, I'm afraid. But I understand that it was a conspiracy between these 3 people that made the job happen. You know, Owen had this idea that he wants an academic department in Brighton, and there is a huge opportunity here to tie in the clinical work that's going on in a big trust, very big trust now, and a new and active medical school. So my job coming down here is to try and get the research in the intensive care up and running and sustainable for the future. So that is what I'm here to do, and it's thanks to these people that I've got this opportunity. We believe that someday in the near future we might move into the new building, but it's being held up slightly at the moment. And then, so just to introduce you to the intensive care in Brighton, I have 18 colleagues. I'm the 19th, and it is a phenomenal team. One of the plus sides of COVID is that we've been thrown together in a way that we wouldn't have worked together before, and we've become a very close-knit and very supportive team to each other. I don't think there's any one person there that stands out and, in terms of not being part of the team, and it's a huge pleasure to work with everybody there. And everybody's got their interests and skills, and you know, I feel very lucky to be part of this team. Just to say, we've got 39 beds over 3 sites, so we all do a 1 and 6. We cover the PRH hospital as well as 2 sites at the county. We've got over 200 nurses, very well managed by our matron and our nurse manager, Lucy and Claire. And we've got a diverse group of trainees. We have an increasing number of advanced critical care practitioners that can do some of the doctor work, and you'll realise the significance of this as I talk. We've got some phenomenal allied health specialists. In particular, from my point of view, the pharmacists are fantastic, and we are developing their role in the unit. So back to individualizing chaos. So I'm going to take you through what's been going on most recently and where things are developing. When I talk to students and people, I ask them, what's the one thing all doctors do or have done in their career? There's only one thing. You know, we all develop different skills. I suppose we've all examined a patient, we've all spoken to a patient, but actually, in terms of therapy, we all prescribe drugs. Now, things are changing a lot, and Mike's here today, and he's our professor of pharmacology, and he is, he has a huge teaching program now for our undergraduates. When I did it, we did a bit of pharmacology in the first year, and then it was never mentioned again. Certainly not during the clinical time, and certainly not as when you were working. And so we rely on this text here called the British National Formulary. And it is our go-to book. It's published, it's tied in with NICE, which is our National Institute for Guidance for Therapy. And you know, you go to the BNF and you say, what's the dose of drug X? Oh, it's 200 milligrams. Give your patient 200 milligrams of that drug. Everybody does what the BNF tells them. Whoops. The problem with this, it's not actually particularly logical to do this. The BNF is written based on this chap here. A lot of them are medical students. They turn up to studies to earn a bit of money. They're healthy, and they give them drugs, they measure levels, they measure the pharmacokinetics, and doses are worked out. It's the ubiquitous 70-kilogram man. But of course, as we know, people come in slightly more varied shapes and sizes. So even in the healthy population, if you take just the simple body habitus, that is going to, it's illogical to give them all the same dose of drug. This is amoxicillin, clavulanic acid, otherwise known as comoxiclav, and everybody gets 1.2 grams TDS, whether you're 45 kilos or 145 kilos. In addition to this, the body composition of healthy people varies as well. We are not all the same. If you're 70 kilograms with a normal lean body mass, your total body water will be 42. If you're extremely fit and been in the gym all the time, it could be much higher. And although we normally think of fat as not affecting the total body water, it actually does increase the amount of total body water. So if you're giving a drug that's soluble in water, it's going to spread differently in different people. And so the concentration you reach will not be the same in equivalent people. And then if you add to that the impact of illness, you've got a really wonky system. Because not only have you got changes in the body habitus, there might be the impact of immobility, loss of muscle mass, immune failings, inflammation. All these things will alter the amount of fluid that a patient retains. And then if you go into things like some of the chronic illnesses like chronic liver disease, I mean, a patient can have 6 plus 8, 10 litres of extra fluid in their abdomens. And we don't take account of that when we're giving a drug. It's complicated. It's really difficult. And to top all of that, acute illness does all of that, but it does it quickly and suddenly. So there are no adaptations to it either. So one of the problems for prescribing is the idea of first do no harm. Of course we shouldn't do harm to patients, but it's actually not an accurate saying. It comes from one of Hippocrates' first books. It's not part of the actual Hippocratic Oath, although people often think it is. And what it actually says, it's much more nuanced than that. It says, in illness, one should keep 2 things in mind to be useful rather than to cause no harm. But the first do no harm sort of philosophy has meant that people go up to a patient and they go, oh, that patient's kidneys aren't working too well. I better cut the dose because I don't want to cause illness by overdosing them. What they are actually doing is they're not giving enough of the drug to give the effect. So we need to think a bit more cleverly about it. This is an illustration of what I mean. So if this test tube is the concentration of drug, at one end, you've got the very clear and tangible harm of toxicity. If I give too much drug, that patient is going to be poisoned. I am going to harm them. I must not do that. Very sensible. On the other hand, you have this green zone, which is the ideal drug amount, your low risk of side effects. The drug is doing what it needs to do. All is good. And then you've got this lower section, and this is the one we're not so good about thinking about as clinicians. It's not tangible. We don't see it happening in front of us. But if we don't give enough drug, then it won't do what we think it's going to do, and we risk therapeutic failure, and in intensive care, that may be increased risk of death. So we've got to think of three things. First of all, we need to think, how quickly does the drug need to reach a certain concentration? Is the level of drug we need got a critical concentration to reach? How wide is our therapeutic index? Can we be relatively careless about it because we're not going to do any harm? We've got a big margin of error. And third, how dangerous is an overdose? We have to think about that. So, for those of you, just to explain some terminology, we have two major areas of science in this. We have pharmacokinetics, that is how a drug is handled by the body. So how you take it in, how it spreads through the body, is it metabolized, how is it excreted? And then we have pharmacodynamics, is what is the actual drug doing to the body? And you can think about them somewhat differently because they are related, and they will be affected in different ways by illness. So broadly speaking, a drug works by getting into the circulation. It gets to the site of action. It sits on a receptor. The receptor is there for something else, for endogenous ligand. It sits on the receptor, and depending on how responsive the receptor is to the drug and how many receptors are affected, you get a dose response. So if you give a little bit of the drug, you don't get much, and then as you give more drug, you get a much better response until you get to a maximum response, and so everything's good. If you give more of the drug, you shift the curve to the right, and this becomes more toxic and then eventually lethal in some cases. Some drugs will block the receptor, and they're known as antagonists. They act to block the receptor, but again, they can have lethal dose too. So essentially, that's how drugs are working on the body. And I'm not going to go into much more about that than this, because actually a lot of what happens in critically ill patients is around the pharmacokinetics, what the body is doing with the drug. And we've got two problems to think about. We've got to think about if a drug's accumulating and becoming toxic, or if we're not giving enough, as I mentioned, and it's not actually getting to the level that we want it to. So what are the factors which complicate prescribing in intensive care? Well, it's complicated. And this is where it becomes very, very difficult. I'm going to go through a little bit of this, not too much of it, you'll be pleased to know, but I'm going to go through a little bit of it in turn, because it's some of the work that, mostly my PhD and MD students were doing, so we'll take you through those. So I'm going to talk about the accumulation of drugs first. Kidneys excrete most drugs, either the drug itself or their metabolites, and the metabolites may be active or inactive. We have a condition called acute kidney injury when patients come into intensive care. So somebody's kidneys can be completely normal, or they might have a degree of renal impairment anyway. Something happens to them and the kidneys shut down, for want of a better way of describing it. And we call that an acute kidney injury. If it's managed quickly and properly, in most cases it reverses. In most cases it reverses fully, but it doesn't always. And some people go on to develop long-term kidney problems. Chris is here tonight. He'll explain this far better than I would, but one of the things we did, one of the ways we assess kidney disease is we look at the serum creatinine. The serum creatinine is a product that's developed related to muscle mass. It is excreted by the kidneys, and we use it to measure kidney function. And the relevance of this to here is that we use particularly this equation to describe kidney function in intensive care patients. We say, we do a value, we find that their function is poor, and we change drug doses. The trouble is, the equations are incredibly inaccurate and are meaningless in acute kidney injury almost. But because that's the only tool we've had, it's the only tool we use. But there are a lot of problems with using serum creatinine as a marker of renal function. So you alter the amount that you produce when you're critically ill. Your kidneys start handling it differently. It secretes it instead of filters it. All sorts of things happen so that creatinine is not a particularly useful marker. Another thing you can do, and this takes me on to another PhD that we did previously, is that we can give another substance. We can choose a substance that we know that if we give it to the patient, it will only get excreted by the kidneys. And if you do that, the levels go up high, and then they fall away, and you have two areas to think about. One, the first fall is due to redistribution and elimination, and the second is elimination only, and it's that second equation that will give you a measure of the renal function. The only trouble with using this, if you've seen this graph before, is if you give it and it's only excreted by the kidneys. If somebody's got poor kidneys, if you keep giving it, it will accumulate and it becomes less and less useful. So we can only do it once or twice. It's not really particularly useful in a situation where kidney function is changing rapidly. It's getting better as well as worse. It's a very complicated picture. So John, who couldn't be here today, did studies looking at using a very low dose of iahexol, which is actually a radiology dye. It's something that's given to patients for x-rays, but it's only excreted by the kidneys. We used it at very, very low infusions, and we put it on patients for 80 hours at a time, and we wanted to see whether we could measure the GFR, the renal function doing that. To start with, we tested it in healthy volunteers and patients with chronic kidney disease, and fortunately we came up to the conclusion that actually it was extremely sensitive, a very good way of doing it, certainly in healthy patients and patients with chronic kidney disease, and the limits of agreement were good and the correlation was very tight. We then decided to take a Donald Rumsfeld approach to research, unknowns and knowns and unknown knowns and known unknowns. And we developed 3 groups of patients, and we wanted to study whether it would work in acute kidney injury. So in this case, we took patients who who were coming into intensive care because they'd had to have one kidney removed. Now we've got 2 kidneys, so assuming both kidneys are working roughly the same, if you take one away, your renal function's halved. So we could measure that. We knew that would happen. We then took, so that was our predictable and predictable. We then did vascular patients. Again, we knew when the insult was going to happen. We knew when the trigger of the acute kidney injury was going to happen. That was going to happen as the surgeon stuck a big knife into the patient and caused the response that caused acute kidney injury. So a predictable trigger, but completely unpredictable whether they would get an acute kidney injury or not. And then we had the last group, who were just people coming into intensive care with low urine outputs, and we thought they might have acute kidney injury. So they were the unpredictable and unpredictable. And what we found is, very satisfyingly, we found that it seems to have changed its mode. So we found very satisfyingly that the nephrology group did, by all accounts, reduce their GFR by half, which is very encouraging. And then we looked at vascular and AKI patients, and we were able to describe in better detail whether people developed an acute kidney injury or not. And in fact, what we found is that the criteria that I showed you earlier overdiagnosed in some patients and underdiagnosed in some patients, so that we're confident that this method, and we hope to use it in the future to test other biomarkers, is a way that we can go forward. It's a research tool. It's never going to be a clinical tool as such, but it's a tool that we're using to go forward. This brings me on to the liver, another source of accumulation. I'm going to be quite brief about this, but essentially the liver metabolizes drugs mostly through 2 major enzyme systems. There are loads of these enzymes in the liver, and the liver is very forgiving in acute illness. We don't run out of the capacity very often, unless the hepatic blood flow changes, and then hepatic metabolism may be affected. The other area where hepatic metabolism of drugs may be affected is if we've got either induction of the enzymes by some of the drugs we use or inhibition of the enzymes by some of the drugs we use. So Chris then looked at the interaction between the kidneys and the liver, because we hypothesized that if your kidneys were very bad, that this issue of organ crosstalk, if one organ fails, it's going to affect other organs. Some of it's quite obvious. If your heart doesn't pump, then you don't get blood supply to the gut or the brain, and they might fail. But there are more subtle crosstalk as well. And so the thing that Chris was looking at was the crosstalk between the kidney and the liver. And we used midazolam, which is only metabolized by CYP3A4, and we gave patients tiny, tiny doses of midazolam. It's a benzodiazepine. It's a drug that is used for angiolysis. And we measured its level at 4 hours. And we did, in fact, show that as your kidneys get worse, your liver function deteriorates in terms of CYP enzyme function. We also looked at the other enzyme that I showed you, and that didn't have such a great effect. So, but it's important when you're starting to think about all these things that tie together how we're dosing drugs, you can see how complicated it gets. So what about subtherapeutic? Well, I'll bring it back to this terrible diagram really here. And when you become very ill, when you become septic or you have major surgery, what happens is you develop inflammation. That endothelium that I showed you earlier releases lots of mediators, IL-8, IL-6, all sorts of things, and it makes the tissues leaky. If anybody's had a relative or been a patient in intensive care, they know they get very swollen. Everything puffs up. And it puffs up because all your tissues have become swollen. It's in order to allow mediators of immune system and cells of immune system to get to the site of infection. And when you're very unwell, it becomes dysregulated, so it affects the whole body. And then add to that, so you've got this very swollen, because all the fluid's leaking, proteins levels drop as a consequence, and then we come along and we give lots of fluid. And so somebody who has lots of volume somebody who's normal circulating volume and interstitial volume, that volume just outside the circulation is normally about 20 litres. I've seen measurements of up to 90 litres in somebody who is very unwell. And you're giving that 1.2 grams of cloamoxiclav, instead of into 20 litres, you're giving it into 90. It can't get to the same concentration. So there's increasing evidence now that drugs given in intensive care acutely, those first doses don't get to the levels we need them to treat illness. And this has been shown most clearly in the beta-lactam antibiotics, penicillins, those sorts of drugs. So what you do want is this, I'll do it this way. What you do want is you want a time above this minimum concentration. You need the drug to get above there to kill the bugs. And you want it to be above that for as long as possible. If the green curve is normal, the blue curve below is what happens in critical illness. Because you've got all this fluid on board, it never quite gets to the levels for long enough that you want. This is by Dagan. Dagan couldn't come tonight. This is his PhD, and he was looking at beta-lactam levels in patients from the age of 0 to the age of 90. Now, postmenstrual age in years is your age plus the number of months since your mother's last menstruation. How they worked it out for the 90-year-olds, I'm not sure. But certainly that was the, so he did it across, so he was taking bloods in the neonatal unit, pediatrics, and the adult. And as you can see on the red are the critically ill patients. And as you can see, this is the first one is the volume of distribution, so it's that volume you're putting the drug into. They are widely variant. You can't predict what it's going to be. And then on the second one, it's clearance, so how quickly your drug is getting cleared. Some are very poorly cleared, some are being cleared very fast, and these are all intensive care patients in the red. So again, it just shows you how complicated this is to understand and measure. And if you look at amoxicillin here, if you go for the levels that are sometimes wanted for intensive care patients, for your sick of your antibiotics, 1% were getting enough antibiotic on the standard dosing. 36 if you took the bare minimum dose requirement for treatment. So we have to think of a different way of prescribing drugs. So what is required? We need to individualize drugs, prescribing much better. We also need to use dynamic prescribing. What tends to happen in medicine is you say, that patient is going to get 1.2 grams of co-amoxiclav 3 times a day for the next 7 days. It doesn't take into account any of the changes. They might need more, they might need less at any time. And we need to be much more clever about going in and saying, no, we need to increase the dose today, we need to decrease it. Trouble is we don't have the data to base it on. And what we really need is therapeutic drug monitoring. At the moment, if I want to measure co-amoxiclav, I'm going to take a sample. It's going to go to Bristol, and I might get a result in 2 weeks. The technology, the science isn't quite there. So, I'm not going to go through all of this at the moment, but at the moment, I'm trying to evolve and develop a pharmacokinetic study group in Brighton. We put in some money for a big grant at the moment. Pharmacokinetics isn't seen as terribly important by the funding bodies at the moment, so I'm not holding my breath, but it's there. You never know. They haven't kicked it back quite yet, so that'll probably be in tomorrow's email. But I've got a great team. They've got Greg here, who's our from the pharmacology department. We've got Kathy here, who is a consultant pharmacist in Southampton. We've got Mike. We've got a great team here to drive this forward. And I'll show you one of my colleagues' work in a minute. But I'm going to show you this. This is something that I'm very proud of. There are 2 people in here who it wouldn't have happened without. So so I'm going to share this with Kathy and Chris. Essentially, about 6 years ago, there was a big meeting in St Thomas's. We all got together. There were critical care pharmacists and there were intensive care consultants. And we all agreed that the BNF wasn't fit for purpose, and the renal handbook didn't work either for critically ill patients. Kathy had arranged this meeting, but wasn't feeling too well at the time, so she said to me, would I mind taking it forward for a bit while things were sorted out? And so I sat at home thinking, well, what do? I've got all these people interested, but unless we have an output, we're going to lose them quite quickly. So I rang the Farm Press, the people who published the BNF, and said, could we have a meeting? Told Kathy and Chris, and Kathy came, I think, on the first meeting. Chris came in the next one, I think. Is that right? Yeah. And we went there, and we sat down. We said to them, we don't think the BNF's fit for purpose in intensive care. And then thought, oh, that sounds a bit rude. And they turned around and said, we know. Because actually what we were talking to, all the people there had worked in critical care. They were pharmacists who turned editors, turned into publishing. They just happened to know about critical care. So we pushed an open door. And they said, would you like to write one? And so this is what we've done. And I'm going to show this because anybody who is affiliated to the University Hospital Sussex can do this now. This is now available to everyone. It's available throughout Scotland and Ireland. In England, it's got to be trust by trust. So I'm just going to show you. So I'm going to log in as myself, using my Open Athens login. It works. So you go to NHS England, you put in your Open Athens, and it will take you to the platform. This is the same platform as the BNF, and the publication is called Critical Illness. So if you put comoxiclav in, you can then press on that, and it will take you to the monograph. There's an introduction, tells you a little bit about comoxiclav. Indications, it tells you a dose, and if you see there, we've already suggesting we can only go so far at the moment, but we've suggested a higher dose than is licensed in the UK, and we also suggest that you should be giving this for the early part, even in patients in renal failure. We've included a section on dose adjustments, and we've done it for acute kidney injury, for renal replacement, for CKD, for other forms of renal replacement, and things like extremes of body weight and liver disease. And then we move on, and you can look up, if you're a student, you can look up to see how the drug works. And then I'm quite proud of this bit, the pharmacokinetics. We've put in a section describing the standard pharmacokinetics and the pharmacokinetics as we know it, because there's a lot of data still in critically ill patients. There's then a section of important considerations, and our hope is that therapeutic drug monitoring will end up there. And we keep reiterating this. In critical care, doses need daily review. And then it's all referenced. So just to tell you a little bit about the other sections. So we started this. We published the first 6 drugs at the beginning of COVID. And these are the drugs we now include in the publication. We also give a little bit of prescribing advice. There's a chapter being written at the moment on how to use weight, and another one on AKI. They'll be added as they are prepared. And just to introduce you to some of the team, I think yes, that tells you a little bit about the publication. And then if I tell you about the team in a moment. I only discovered how to do this on PowerPoint yesterday. So, so editor-chief Kathy and Greg, who's a pharmacist up in Knoll. The editors are from Scotland, from Australia. There's Dagan in George's. We've got a fantastic group. And then we've had many. There's a couple of our critical care pharmacists on there who have been contributing monographs. Got an excellent team of advisors who help us with specific issues like ECMO and things like that. And they're from, so we've got Sandy Gill from Pittsburgh, and we've got Roberts from Australia. And we have a fantastic team of editing pharmacists from Farm Press. So this has grown like a mushroom, and it's fantastic. And it's a real, I'm really proud of this. And we hope that more and more people will have it available so that they can actually think about prescribing in this group of patients. So I'm almost done, you'll be pleased to know. I couldn't finish without pointing out that I came into a unit that was very open-minded about this area of research. This has nothing to do with me. My colleagues, Becky, Fiona and Owen and Greg, who's here, was looking at fentanyl and the prescribing of fentanyl before I even arrived. And this has been published, and we hope to develop our group for the future. And the other thing I'd like to point out is that nothing happens in isolation. We've got some amazing collaborations developing, both internally, not all related to prescribing, and externally. And I think one of the beautiful things about intensive care is that it's such everybody works in intensive care is always dependent on people around them, so collaboration comes very naturally. and more naturally than giving a lecture like this does, I can tell you. And that is where I'll finish, so thank you very much.